Well, thank you all for staying. You are the warriors, I guess, of the conference. Okay, here I go. So in talking in general about GI toxicity and cancer, this is really the most stressful issue that patients anticipate during any sort of therapy for cancer. They are commonly overlooked, and it's hard to overlook these LFTs, but certainly some of the other GI toxicities are very easy to overlook during the focus on response. But in the end, most GI toxicity can be well managed if we're on top of it. So in general, specific to targeted therapies, the spectrum of GI toxicities is wide. Very few of them are well defined. Many normal cells of the GI system include the targets that are being targeted in many of these agents. And as we talked about in the last presentation, sometimes the GI toxicity can also correlate with response, like skin toxicity. There are lots and lots and lots, you know this, of drug-drug interactions, and our patients are on lots of drugs. And then, of course, the GI toxicity varies widely from single agent use to starting to throw in other agents. So I'm so glad that there was a large percentage of people not sure about the grading, because for those of you who are not doing clinical trials every day, in our clinical trials, grade 1 and 2 are usually considered mild and acceptable. And so I wanted to flash grading up for these items, because really when you look at grade 2 diarrhea, an increase of 4 to 6 stools per day over baseline, to me that's really not so mild in terms of quality of life, especially when you're giving oral agents long term. These really have a bigger impact on life than a few days of grade 2 diarrhea after an IV agent, and then you're not going to get it again for 3 or 4 weeks. So keeping that in mind is critical here. So diarrhea in general is a major cause of treatment discontinuation. It's a very common dose-limiting toxicity. And so you can see the prevalence here. This is really a problem with many of these targeted agents. Most diarrhea is not severe, but again, grade 2 is 4 to 6 stools a day over baseline. So some of the thoughts about this is that EGFR is overexpressed on normal mucosa and potentially leading to a secretory diarrhea through that mechanism. With imatinib, it's purely dose-related. Bortezomib tends to give watery diarrheas. Temsirolimus, there's the immunosuppressive and antimicrobial effect that could be altering the bowel flora. So we have some idea on some of these. And then with gefitinib, inflammatory mediators in response to cell-mediated cell immunity activation. So we do have some theories on some of these, but when push comes to shove, it's pretty foggy what is happening in the GI system with diarrhea. So for management, of course, hydration, electrolytes, diet changes, do cultures, loperamide, octreotide, you may need to do antibiotics. And then there's suggestion of low-dose aspirin with gefitinib, specifically because of that, its unique mechanism of action. So nausea and vomiting. So let's just take a second to look at this. And so nausea is really not considered severe unless people are getting inadequate calories or fluid or require tube feeding or hospitalization. And then for vomiting, 6 episodes, at least 5 minutes apart in 24 hours is considered severe vomiting. Again, you're asking somebody to take a pill at home every day that's causing some of these grade 1 and 2. That they are a problem. But again, we tend to overlook those. I also think that when you hand somebody a prescription for a pill and send them out, the attention they get is very different than a patient who's getting these agents in combination with chemotherapy, and they're in seeing your treatment area nurses all the time and getting a different support from our healthcare system. So if we look at nausea and vomiting, if you look at the NCCN guidelines, and all of them have minimal to low emetogenic potential, but the prevalence is quite high. So again, asking somebody to tolerate grade 1 or 2 nausea and vomiting long term is very different than having a few days of nausea and vomiting per cycle. So nausea and vomiting truly is the most concerning symptom for patients. There are quality of life impacts, like we heard with the dermatology issues, and it's affected by so many things: the agent, the dose, the schedule, all of our patient-related variables, very multifactorial. And again, most of these drugs on paper should not cause a lot of nausea and vomiting, but we all know that that's not necessarily the case. And then in the literature, there is discussion about the need for a revised CTC to reflect our targeted therapies versus our traditional chemotherapy. Again, tolerating 4 to 5 stools over baseline as a grade 2 has a very different impact. So again, follow guidelines for prevention and treatment, hydration, dietary changes. There are I could have talked all day about the non-pharmacologic options out there. For some patients, they really do work. For others, they're not the home run, but it's not all just about drugs. So for low to minimal, if it's a low agent, you've got your sort of intro antiemetics, pre and PRN, steroids, metoclopramide, some compazine, lorazepam. You can consider H2 blockers or PPIs. And then with oral agents, PRN antiemetics are recommended for prophylaxis. So our last speaker talked a little bit about, and I'm just talking about mucositis, but again, looking at the grading, moderate pain is acceptable with no change in oral intake or needing a modified diet. And truly, many of these agents are not causing severe, but as we saw in the previous slide, some of them are big offenders. And then this is the incidence of stomatitis and mucositis. And again, there is a truly real incidence in these patients. Again, it's the folks who get the prescription and walk out the door who are really most at risk for developing more severe side effects because we're not watching them like a hawk so much. So management, and again, saline rinses, I love that slide about the magic mouthwash and everybody's got it and everybody orders it, but saline rinses really do work. Just common sense things, soft toothbrushes, hydration, making some dietary modifications, and always keeping infection in the back of your mind is critical. Dyspepsia is another issue with these agents. Again, moderate symptoms requiring medical intervention is considered acceptable. And there is a very real incidence of dyspepsia with these agents as well. So just really thinking about, to me, the issue is more with handing someone a prescription and sending them out the door. What is going to prevent that person from being compliant with their regimen? And these are some really easy things to talk about and to get on their radar and to have them calling in for if they have issues. So again, pharmacologic treatment, but this pitfall of drug-drug interactions always needs to be considered and thought of carefully. Dietary changes. And so liver function abnormality, as you all know, these drugs, most of them can cause liver function abnormalities, and the grading is here. So you can those are in your slides, that was our case study. And so if you look at the incidence, it varies widely, but sunitinib and sorafenib are really the highest offenders in that group. Again, I do not try to remember any of this. I always go to the package insert and figure out, is it time to hold, is it time to, but some of it is patient specific. If the LFTs are really starting to skyrocket very suddenly, you really may not wait for them to get to a certain grade to do something different. And then, of course, we're all aware of GI emergencies with our targeted agents. We know bevacizumab can cause GI hemorrhage, perforation, colitis. Bortezomib can cause paralytic ileus. Imatinib, also hemorrhage and perforation, and also gefitinib and erlotinib have perforation incidences, although they're rare. And so in conclusion, our targeted therapies, and I just took a subset of them it's hard to include all of them. They have a very high incidence of GI toxicity, usually mild, but often overlooked. And then again, this chronic dosing schedule of many of these agents, we just need to think about them differently. Hopefully, eventually, we will have a CTC that's targeted for oral therapies, but just don't forget about some of these things that are not necessarily life-threatening, but do impact quality of life. And I think that's my last slide.
Very good, Amy, thank you.